So we're going to be going through necrotizing fasciitis. Once again, this is for board review purposes, educational purposes only, and also it goes by our local antibiogram as well for certain parts. It may not be completely generalizable to where you're practicing. But going through necrotizing fasciitis, pathogenesis, microbiology, there's basically in the literature, there's two different types of necrotizing fasciitis. The first type, we'll say, is going to be type 1. So type 1 necrotizing fasciitis. In this one, this is going to be a polymicrobial infection, okay? So type 1 is polymicrobial. So you can have gram-positives, gram-negatives, as well as having anaerobes present in these current infections. For this infection, usually they gain entrance somewhere near mucous membrane. So this includes necrotizing fasciitis of the head and neck, as that's near the mouth, as well as the perineum, called Fournier's gangrene, as well as chronic wounds. Here is a chronic, diabetic foot ulcer that's getting infected. Most of these infections are going to be people with pretty severe immunosuppression, diabetes being, severely uncontrolled diabetes being one of the biggest risk factors. So that goes through your type 1 necrotizing fasciitis, which is monomicrobial. Next we're going to go through is type 2. So type 2, this is usually monomicrobial, or this is monomicrobial. So the specific bugs that can do this, usually it's going to be group A strep, but you're also going to have staph as well. A lot of times these get into the tissue from hematogenous dissemination and then spreads, unfortunately, down fascial planes, causing worsening infection. It's really hard to get source control of. So what are the manifestations of necrotizing fasciitis? The things that you look at is these patients usually will have pretty high systemic toxicity. You can use something called the Ledrick score to kind of estimate how much systemic toxicity that they have, as well as how much end organ dysfunction that they have. These patients should really have a lot of both. But that score is not sensitive enough to adequately rule out necrotizing fasciitis. For the ones that you're going to see on physical exam, things they're going to be looking at for necrotizing fasciitis, that should really clue you in. I'm going to go through these in order of sensitivity. So most sensitive to least sensitive findings, which means really these can be, the more sensitive finding could be somewhat helpful to really decrease the probability the patient doesn't have necrotizing fasciitis if they do not have these manifestations. First one's going to be that severe pain. Severe pain, as well as poorly demarcated erythema. And kind of going along this poorly demarcated erythema as well is going to be edema and pain outside of erythema. So it's spreading beneath the skin and soft tissue, well, beneath the skin. It's spreading along the fascial planes, which means that erythema may be a little bit poorly demarcated, as it may be infected underneath the skin, and not, sometimes the skin itself. And you will maybe see in certain cases edema and pain outside of that erythema, because once again the infection is spreading through the fasciae, not underneath the skin, which means it might be a little bit outside where that local inflammation is. Some things that are a little bit less sensitive, and this one's about 50%, is going to be crepitus. Now, crepitus has to be secondary to a gas-forming organism, which most commonly is going to be in a type 1 necrotizing fasciitis, group A strep, staph. Other ones that you see with type 2 as well that I didn't mention is going to be Vibrio vinificus and Aeromonas. These are usually really not gas-forming organisms, so they really shouldn't cause crepitus. But your polymicrobial may have anaerobes, may have gas-forming organisms there, so they really should cause crepitus and gas on exam. Last one that is going to be a little bit less common is local skin manifestations. There may be toxin production with necrosis. There may even be bullae formation as well. These are relatively specific but less sensitive for necrotizing fasciitis. So what is going to be your workup for necrotizing fasciitis? One, everyone needs blood cultures. So just like any severe infection, blood cultures before you start your broad spectrum antibiotics. Two, the one thing that can help you as well is going to be a CT scan. So CT with IV contrast. The sensitivity and specificity for this are both about 90%. Things that you're looking at on that CT scan, one is it's going to be secondary to that type 1 neck fash. You might see some of that air in the skin and soft cutaneous tissue. But anyone type 1 or type 2, you really should see enhancement, edema, inflammation of your fascia, which you can kind of see outlined in these white arrows right here. Lastly, and this is really going to be your gold standard. Now, maybe you don't have a huge suspicion for neck fash, but you want to roll it out, a CT scan as well as a surgical consult might be okay, but really high clinical suspicion, anytime you're concerned about necrotizing fasciitis, you need a surgical consult. And the reason why you need a surgical consult, the gold standard for diagnosis is one, on gross visualization, you may see that they call dirty dishwashing fluid that you see on exam right here, secondary to that infection. It causes a exudate that looks in some ways, I guess, similar to dirty dishwasher fluid. Again, it's sudsy. Lastly, cultures, it's going to be of extreme importance as well. So what's going to be, well, let's actually go through type 1 and type 2 neck fash first, and then maybe we'll go through empiric treatment. Actually, let's go through empiric treatment first. So what is going to be empiric treatment for everyone? If you don't know if it's type 1 versus type 2 neck fash, you really have to cover all of the organisms that could cause either one. So your typical broad spectrum antibiotic you're going to use in this case is going to be something that has good gram-positive broad spectrum coverage, so something like vancomycin. You can use dapto as well. Daptomycin as well, and then you're going to need something that has good gram-negative and pseudomonas coverage as well as anaerobic coverage for that type 1 polymicrobial neck fash. So there's definitely some different things you can do at our hospital. One of the first things that's recommended, but this may not be the same on Mixap as well as the same on UpToDate, would be cefepime plus metronidazole, or you can do something that covers all of them, anaerobes, gram-negatives, including pseudomonas for that polymicrobial infections, and that would either be, you can do Zosyn, which is piptazo, or you can do a carbapenem. The other thing that you do need to consider in these cases is that necrotizing fasciitis, and specifically type 2 necrofasciitis, comes with toxin production. So for toxin production, you're going to want to also add on something that targets the ribosome, a ribosomal inhibitor that decreases toxin production at the same time. Your choices here to add on is either Clinda, or at our hospital we can use linezolid as well. So that's going to be your typical go-through for empiric coverage. You don't know it's type 1 versus type 2. A typical at our hospital would be vancomycin, cefepime, metronidazole, plus clindamycin, or plus linezolid. Or you can do piptazo plus vancomycin plus a ribosomal inhibitor, or carbapenem plus vancomycin plus ribosomal inhibitors for the purpose of the test. The reason why you can't use linezolid as the only treatment for the gram-positive infections, it does cover MRSA, MSA, and group A strep, is because it's bacteriostatic, not bactericidal. So you really need to use a medicine that's bactericidal for empiric coverage of your gram-positive, which is vancomycin or daptomycin. Now, let's say you do delineate that it is more secondary type 1 necrotizing fasciitis, which is polymicrobial. You can use basically the same here, vanc or dapto, and you can use the same here as well, which would either be doing cefepime, as noted above, cefepime plus metronidazole, or as noted above, you can use a monotherapy that covers gram-negatives and pseudomonas as well as anaerobes, something like piptazo or carbapenem. Now, you do not need to use a ribosome inhibitor, as type 2 necrotizing fasciitis is the one that you need to do a ribosome inhibitor with. Now, for type 2 necrotizing fasciitis, then I'm going to say specifically when it's their secondary to group A strep, the thing that we're going to be using here is group A strep and strep species in general, usually sensitive to penicillin. So you're going to use high-dose penicillin plus ribosome inhibitor, which is either Clinda or linezolid. And this is actually also the same exact treatment for gas gangrene, secondary to Clostridium perfringens as well. Usually this causes more gas forming infection in your muscles, sometimes can cause a necrotizing fasciitis, but a lot of times more of a necrotizing myositis. But it does have the same exact treatment of penicillin plus a ribosome inhibitor, so I just want to try to include it here. So that is your pathogenesis, microbiology, manifestations workup, as well as treatment of necrotizing fasciitis. I will add some other stuff on. So if you do think the patient has group type 2 necrotizing fasciitis and they're in shock and you're worried about strep or staph toxic shock syndrome, you will add IVIG, so if toxic shock. And lastly, there is 2 organisms, Vibrio vinificus and Aeromonas, and these are a little bit different. For treatment-wise, Vibrio vinificus is ceftazidime plus ceftazidime plus doxy, Aeromonas is Cipro plus doxy. If these are in your differential, this is basically per up-to-date expert opinion. It's not evidence-based, and you won't be tested on. But empirically, for these cases, you could consider adding doxy as well. And then once you get one of these Vibrio or Aeromonas on culture, you would then de-escalate for Vibrio to ceftazidime plus doxy, and for Aeromonas to ciprofloxacin plus doxy. Perfect. So that's everything I got. Hope you guys enjoyed the session for necrotizing fasciitis.